Now it should work.
Yes.
Thank you. So good evening to everybody in Hyderabad, and good morning to folks like Venkat Subaya in the US. And thanks for joining this webinar, sacrificing your valuable Saturday evening. So this is all what it entails being a physician, unfortunately, sacrificing family time for some of these activities. And thanks, Dr. Kavita, for kind introduction. Whatever little I have achieved is because of God's grace and blessings of gurus and best wishes of my collaborative friends. And I'm really grateful for Drs. Joga Rao, Vijay Bhaskar, and Dr. Kavita for giving me this opportunity to present this talk on renal cell carcinoma and some of the recent advances. I was not fortunate to see Dr. Subbarao in flesh, but he is very much still alive in the institutions he built, in the trainees he mentored, and also creating various educational platforms, including CREST. And I'm grateful to CREST for giving me this opportunity. While being a resident in Bombay, one of the very few people my chairman, Dr. Ravi Ramakanthan, had very high regards in academic radiology was Dr. Kakalla Subbarao. I knew that he was a brilliant radiologist, a visionary administrator and leader, and a great role model for innumerable mentees and students, and a phenomenal teacher who really inspired many people to take up radiology and have that passion for radiology. Yesterday, I was going through some of his YouTube channels. I didn't understand much of his Telugu-based commentaries, but I came to know that he was from a very modest agricultural family. And his first intention was to join an engineering school. So what the engineering school lost was a great gain for radiology. So with this and with a sense of gratitude, I would like to start my talk on kidney cancers, the latest advances. We all know that renal cell carcinoma is one of the most common kidney cancers, comprising almost 90% of all kidney cancers. And it's one of the most lethal urological cancers. We see more patients with prostate cancer, but we see more patients dying of renal cell carcinomas because it's a lethal malignancy. Approximately 20 to 30% of all patients with renal cell carcinomas develop metastasis, and 50% of these patients die within 5 years of diagnosis. There has been an exponential increase in the incidence globally, partly because we are picking up many of these cancers on other imaging studies done for other indications. As with most other cancers, when we catch patients with early stage cancers, it has excellent prognosis as opposed to somewhat grim prognosis in patients with advanced metastatic disease. For a long time, renal cell carcinoma was considered a single disease. Pardon me. So until 1986, there was only one cancer, renal cell adenocarcinoma. And in the 1986, they came up with a classification system called the Mainz classification, where they included clear cell carcinoma, chromophilic or papillary renal cell carcinoma, and chromophobe renal cell carcinoma. Over the past 20 to 30 years, there has been an exponential increase in not only the number of kidney cancers, the various histologic variants, but also important information about what genetic changes and tumor pathways they impact. And also there has been important information about how certain tumors are indolent, why certain tumors are aggressive, and it has a bearing on how we treat these patients with specific drugs, and also it has a bearing on the prognostic significance. According to the 2016 World Health Organization classification schemata, there are three major histologic subtypes of renal cell carcinomas. The clear cell carcinoma is by far the most common subtype that seems to recapitulate the epithelium of the proximal convoluted tubule. The papillary renal cell carcinomas account for 10 to 15% of all renal cell carcinomas, again arising likely from the proximal convoluted tubule. In contradistinction, it is the chromophobrinol cell carcinomas that arise from the cortical collecting duct. They recapitulate the type B intercalated cell of the collecting ducts. And it is the hereditary cancer syndromes, which constitute approximately 5% of all renal cell carcinomas. It is the study of these syndromes that have given us more information about the pathogenesis and the natural history of various sporadic cancers as well. And the remaining around 10 to 12 subtypes of renal cell carcinomas are extremely rare, comprising less than 1% of all renal cell carcinomas. We know that not only do kidney cancers differ how they look under the microscope, but also how they look on imaging studies. A classic example is the hypervascular nature of most of the clear cell renal cell carcinomas because of the presence of thin-walled capillary-like sinusoidal vessels, tumor vessels. On the other hand, most papillary renal cell carcinomas tend to be hypovascular, especially if you look on corticomedullary phase images. So to determine the vascularity of the masses, we need to obtain corticomedullary phase images to determine whether they're hypovascular or hypervascular. Here is a snapshot on the segmental distribution of various pathologies, including tumors. We know that clear cell renal cell carcinoma and papillary renal cell carcinomas arise from the proximal convoluted tubule, and the chromophobrinol cell carcinoma and oncocytoma arise from the cortical collecting ducts. And there are some extremely rare cancers that arise from the renal medulla, very hypoxic conditions that exist in the renal medulla. And some of the cancers that arise from these relatively harsh conditions are extremely aggressive. So the important changes over the past 2-3 decades has been the emphasis on the role of genetic abnormalities that predate some of these tumors. And with this new knowledge, we have identified that that not all tumors are created equal, and they have different metabolism, they have different tumor pathways, they have different pathogenetic pathways, and different sources of tumors as opposed to a single disease with single pathogenetic pathway. And this has led to identification and discovery of some of the tumor pathways, which in turn help us identify some of the drug targets. And we can come up with specific drugs that act on specific pathways. So there has been a paradigm shift in our understanding of many of the tumors, including renal cell carcinomas. As already alluded to, the hereditary renal cell carcinoma syndromes are autosomal dominant syndromes. And what is very interesting is that each syndrome is associated by specific genetics and a specific histologic subtype of renal cell carcinoma develops in each syndrome. And these are difficult to treat because they are bilateral multiple tumors. And this led to the identification of tumor pathways, and also with the premise that can we treat these patients by medicines as opposed to surgery. So this led to the development of many of the targeted therapeutics that we see with other cancers as well. Here is a snapshot on some of the common hereditary renal cell carcinoma syndromes. The von Hippel-Lindau syndrome, it's a multi-system tumor syndrome that is characterized by various other systemic tumors such as pheochromocytomas, hemangioblastomas of the central nervous system. It's characterized by the development of clear cell variant of renal cell carcinoma. As opposed to the von Hippel-Lindau, there are two syndromes that are characterized by the development of papillary renal cell carcinoma. One is the hereditary papillary renal cell carcinoma syndrome that is associated with indolent type 1 bilateral multiple papillary renal cell carcinomas. On the other hand, the hereditary leiomyomatosis syndrome is associated with very aggressive type 2 papillary renal cell carcinomas. And the systemic counterpart is that they develop many skin and uterine smooth muscle tumors, including leiomyosarcomas. The last one, the Birt-Hogg-Dubé syndrome, is associated with the development of so-called hybridomas, tumors that have a component of both chromophobrinol cell carcinomas and oncocytomas, presumably because they arise from the same segment of the nephron. And these patients have characteristic skin lesions and also lung cysts that may rupture, giving rise to pneumothorax. So I try to come to the renal cell cancers from a different perspective of how important information about the genetics of tumors have helped us to understand the biology of tumors and also the natural history of these tumors. So there are two main mechanisms of tumor genesis. One is by silencing of the tumor suppressor genes. This is a prototype example is von Hippel-Lindau syndrome, in which the good gene, the functional gene, is absent or dysfunctional, leading to renal cell carcinoma. On the other hand, there is gain of function mutations in MET proto-oncogenes. It is the promotion of bad oncogenes that lead to hereditary papillary renal cell carcinoma syndrome. Moving on to the prototype autosomal dominant multisystem phacomatosis syndrome. von Hippel-Lindau syndrome. It's almost 75% of patients with, there are several phenotypic variants of von Hippel-Lindau, and types 1 and 2B are the ones that get renal cell carcinomas. And it is characterized by a variety of manifestations within the kidneys. You may have multiple cysts, complex cysts, hemorrhagic cysts, cysts with complex features such as thick septations and mural nodules, and frank hypervascular renal cell carcinomas. So before 1990s, most of the cytogenetics was in the blood cancers or the hematological malignancies such as leukemias and lymphomas. And it is because of these three scientists who got the Nobel Prize in 2019 that we now know what happens in patients with von Hippel-Lindau syndrome. And in general, this was also the first solid tumor where the knowledge of cytogenetics helped us come up with targeted therapeutics or smart molecules to treat these patients' tumors. So von Hippel-Lindau protein is a tumor suppressor protein in that in normoxic conditions, it causes proteasomal degradation of a factor called hypoxia-inducible factor alpha. So in normoxic conditions, the levels of HIF alpha is low because of the presence of von Hippel-Lindau complex or the protein. So when the VHL complex is absent or dysfunctional, as in patients with von Hippel-Lindau syndrome, there is unbridled activation of HIF alpha, leading to angiogenesis, cell proliferation, and metastasis. So here is a simplistic presentation. There is, when the VHL gene is present, the nephrons behave normally because of low levels of HIF alpha. When the VHL gene is absent, there is increase in HIF alpha levels, leading to increase in vascular and other somatic growth factors, leading to clear cell renal cell carcinomas. What is interesting is that vast majority of even sporadic clear cell also employ the VHL pathway. A significant proportion of them also employ the so-called mTOR pathway, which is again dysregulated in patients with tuberous sclerosis. So two common pathways of two common syndromes that affect the kidneys. It is called a clear cell renal cell carcinoma because after the histologic processing, the tumor cells are clear. These are cells that are very rich in glycogen and lipid. And during the processing, they're washed away, giving rise to the so-called clear cell. And what is interesting is that in a small subset of patients, we see this phenomenon of microscopic or intracellular fat on MRI imaging. Here on the left is a patient MR showing a renal mass on in-phase images that shows uniform loss of signal intensity in the posterior aspect of the mass on opposed phase or out of phase images showing the presence of microscopic or intracellular fat. So the presence of intracellular fat is characteristic of clear cell renal cell carcinoma, and especially but we have to keep it in mind that it's seen in only a small subset of patients. The classic presentation is that of a heterogeneously enhancing hypervascular expansile soft tissue mass, as is seen in these images. Notice that the metastatic lymphadenopathy next to the mass is equally hypervascular and heterogeneous. And the right set of images, you have corticomedullary phase and nephrographic images on contrast-enhanced MRI showing intense enhancement of clear cell cancers and with significant de-enhancement on delayed phase images. These clear cell cancers are also associated with so-called tumor shunts, the arteriovenous shunting, and that is the reason for the de-enhancement on delayed phase images in these patients. So before, from a management perspective, renal cell carcinoma was considered as a single disease. Before the advent of partial nephrectomy, most patients underwent radical nephrectomy, even for seemingly small masses. And patients with advanced or metastatic disease got chemotherapy. And unfortunately, only 5% of the patients with advanced or metastatic kidney cancers responded to chemotherapy, the standard chemotherapy. So it's this kidney cancer is a different beast altogether in that they're difficult to be treated by the standard chemotherapy. So based on our understanding of the VHL or the mTOR pathway that these cancers employ, so the scientists came up with specific drugs that act on this tumor pathway, targeting these molecules. So these small molecules are now playing a very big role in the management of patients with metastatic clear cell renal cell carcinomas. And the treatment response is very similar to what we see with gastrointestinal stromal tumors treated by tyrosine kinase inhibitors, in that you see more of cystic changes, and then later you see size changes. So the morphological changes following some of these targeted therapies predate the size changes seen with some of these advanced cancers. One thing, while we are still at a clear cell renal cell carcinoma, is the recent classification of a downgrading of a so-called multilocular cystic clear cell renal cell carcinoma to multilocular cystic renal neoplasm of low malignant potential. And this has been necessitated because most of these so-called complex cystic masses that we see that end up being resected and undergoing pathological evaluation, they tend to be quite indolent tumors and hence of low malignant potential. So again, there is a wide spectrum of patients with complex cystic masses that are otherwise malignant in, by histopathology. And I'll come to those, but this refers to the multilocular cystic renal cell carcinomas with clear cell histopathology. As already alluded to, there is a dichotomy in terms of papillary renal cell carcinomas. The type 1 papillary renal cell carcinoma syndromes are associated with bilateral, multiple, somewhat indolent, low stage, low growth tumors. And on the other hand, we have HLRCC syndrome, which is associated with more aggressive type 2 papillary renal cell carcinoma syndrome. And that is associated with another Krebs cycle pathway gene called the Fumarate hydratase, which is a tumor suppressor gene, and this is absent in these patients with HLRCC. And these patients develop widespread metastasis even at presentation. So in contradistinction to other hereditary syndromes, it is the HLRCC that is associated with solitary tumors with extensive regional lymphadenopathy. Here is an example. I'm showing just one tumor, but this patient also had bilateral multiple hypovascular tumors consistent with hereditary papillary renal cell carcinoma. On the other hand, you see this large, again, hypovascular papillary renal cell carcinoma with associated extensive metastatic lymphadenopathy. So clearly, type 1 tumors are indolent, type 2 tumors are aggressive and biologically very advanced. Now, the latest classification of WHO classification of 2016 has a separate separate classification of these papillary renal cells cancers, and anytime they see type 2 histomorphology, they need to be supported by immunocytochemistry showing loss of fumarate hydratase. So these are now referred to as fumarate hydratase deficient renal cell carcinomas. And notice that quite large hypovascular, and here is a corticomedullary face images, and we see predominantly hypovascular tumors and with extensive metastatic lymphadenopathy, and even beyond the lymph nodes, and they're quite aggressive in that they can have bone metastasis and also liver metastasis. Here is a patient with who presented with a bleeding renal cell carcinoma, and incidentally also had multiple uterine leiomyomas, and also one of them had quite atypical features concerning for leiomyosarcoma. And this patient turned out to be a patient with hereditary leiomyomatosis RCC syndrome. And it is sometimes we are the ones to alert the clinicians to the possibility of a hereditary syndrome based on the constellation of findings that we see. We discussed briefly about the two kinds of hereditary papillary renal cell carcinomas, and now we come to the sporadic cancers. Again, there are two major histologic subtypes, the type 1 and type 2, and these are characterized by the so-called proto-oncogenes. There is gain of function mutations involving the MET oncogene, and these are again associated with hypovascularity. And on MRI, they have characteristic imaging findings, especially they have a high T1 signal and then T2 signal. T2 weighted images show quite low density, low intensity foci because of byproducts of hemorrhage and necrosis. So as opposed to the expansile hypervascular heterogeneously enhancing clear cell carcinomas, these are somewhat bland looking on imaging studies. And these are also some of the tumors that were previously mistaken for just hyperdense cysts. So many of the so-called hyperdense cysts actually are papillary renal cell carcinomas if characterized appropriately. So any lesion that measures 30 to 80 Hounsfield units on non-contrast CT is potentially malignant. And anything that is more than 80 Hounsfield units is a hemorrhagic cyst. Anything that is less than 30 Hounsfield units is a cyst. So this borderline measurement of 30 to 80 Hounsfield units on a non-contrast CT should alert the radiologist to the possibility of a papillary renal cell carcinomas. And anytime we see high T1 signal intensity with associated low T2 signal intensity and hypovascularity on MRI, we should think in terms of papillary renal cell carcinomas. Again, the buzzword here is homogeneous hypovascular. So one of the pathologists explained to me that this is kind of a suicidal tumor in that it grows and dies. It grows and dies, and that's the reason why we have necrosis and hemorrhage being the predominant. And there may be scattered tumor cells, but in general, they tend to be hypovascular and because they tend to die quickly. Again, hypovascular renal cell carcinomas, which are papillary renal cell carcinomas. Moving on to Bartók-Dubé syndromes, again, whenever we see a constellation of lung cysts or pneumothorax in combination with multiple bilateral moderately enhancing, this is somewhat between the spectrum of clear cell as well as papillary renal cell carcinomas. These show modest or moderate degree of contrast enhancement. Again, another case of Bartók-Dubé syndrome, multiple lung cysts and also pneumothorax and bilateral multiple moderately enhancing masses. And it is difficult in these patients, short of biopsy of some dominant lesions, to differentiate between the oncocytoma and chromophobrinol cell carcinoma. So it is a tough diagnosis for pathologists, even when all the appropriate advanced iron staining methods are available for them. And so many of the so-called oncocytic tumors may in fact be chromophobrinol cell carcinomas. So anytime we see fairly homogeneous contrast enhancement and moderate enhancement, these are some of the tumors to be considered. Again, the least common of the major subtypes of renal cell carcinomas are the so-called chromophobe. It is referred to as chromophobe because it did not stain with the regular hematoxylin and eosin stains, and they had a cytoplasm that was kind of opaque. And what is characteristic is the presence of thick-walled blood vessels, tumor blood vessels coursing through the tumor, as opposed to thin-walled and capillary-like tumor vessels within the clear cell renal cell carcinomas. In contradistinction to aggressive type 2 papillary or clear cell carcinomas, it is the chromophobrinol carcinoma which has an excellent prognosis, because most tumors, despite being large and despite sometimes showing heterogeneous contrast enhancement, most of them are confined to the kidneys and hence are low stage. And once you resect the tumor, it is considered cured. And here is the mother of all chromophobrinol cell carcinoma. And notice that there is heterogeneity, some cystic changes, and some calcifications here, and also along the septations. But there was not even a single drop of tumor outside of the kidney. So it is important to make the distinction. Notice that despite the very large size of the mass shows relatively homogeneous contrast enhancement and moderate degree as opposed to the hypervascular tumor enhancement with clear cell renal cell carcinomas. Now, moving on to other subtypes, other rare subtypes. And here is a patient who had a complex cystic mass. And these are intraoperative ultrasound images showing a complex cystic mass with septation and some dependent densities. This was taken out, and this was diagnosed as a clear cell papillary renal cell carcinomas. This is the patient that has both the components of clear cell as well as papillary. And these were initially diagnosed mostly in patients with end-stage renal disease or renal failure. So these were predominantly seen in patients with end-stage disease. But now we see even patients with sporadic clear cell renal cell carcinoma without the background of renal failure or end-stage renal disease. Most of them are predominantly cystic with complex cystic, and there is a small subset of clear cell papillary tumors that develop in patients with even von Hippel-Lindau. So some patients, a very small percentage of patients with von Hippel-Lindau also have multiple bilateral clear cell papillary renal cell carcinomas. And here is another example, a patient with a difficult to diagnose on corticomedullary phase. They say that corticomedullary phase is the graveyard phase for uroradiologists because we tend to miss tumors. And it is seen better on the nephrographic phase images. And notice that it's a well-circumscribed, somewhat homogeneous tumor on ultrasound. And this was, again, clear cell papillary renal cell carcinomas. So not all clear cell papillary renal cell carcinomas are cystic. There is a small subset of patients with solid tumors that end up being clear cell papillary renal cell carcinomas. Now I'm showing you another example, a patient, actually a physician in neighboring city. He noticed that he palpated some lymph nodes while shaving, and one thing led to another, and initially was diagnosed as lymphoma because of disseminated lymph node, multi-compartmental lymph node metastasis. And incidentally, he also had this heterogeneously enhancing right kidney mass. So biopsy showed it to be a renal cancer with both clear cell and papillary, but this was the so-called XP translocation carcinoma, extremely rare. It predominantly occurs in pediatric and young adults. In fact, a third of pediatric renal cell carcinomas come under this XP translocation category. And notice that the size of metastatic lymphadenopathy is way more than the size of the primary tumors. So these are extremely aggressive tumors with frequent lymph nodal metastasis, and these are frequently hypovascular, very similar to the type 2 papillary renal cell carcinomas, which are also hypovascular with extensive regional lymphadenopathy. And characteristic pathological findings of clear cell with papillary architecture, and also the presence of psammoma bodies in these patients with translocation carcinomas. And not all XP translocation carcinomas are very aggressive with with disseminated metastatic lymphadenopathy. And here is another example of XP translocation with heterogeneously enhancing mass and scattered calcifications. And this was confined mainly to the left kidney. So no metastasis. So again, there is a small subset of XP translocations that are not that aggressive as opposed to the prototype or the typical XP translocation carcinomas. Now, we have discussed mostly all the cortical neoplasms. The clear cell, papillary, and chromophobe together constitute 90% of all renal cell carcinomas. And these are predominantly cortical in origin, as opposed to the tumors that we are going to see now that arise within the renal medulla, which is extremely hypoxic. So any tumor cells that need to survive those hostile and very hypoxic conditions need to be quite aggressive. Just like we see the local rowdies in bad neighborhoods, they're typically physically strong and they tend to control the neighborhood. And very similarly, some of the medullary carcinomas are extremely aggressive. And here is a patient, a 21-year-old man with hematuria, and obviously we see quite advanced heterogeneously enhancing left kidney mass with associated metastatic lymphadenopathy. And this patient had sickle cell trait as well, which is the cancer that is typically seen in patients with sickle cell trait. And there are 7 different manifestations within the kidney of renal in patients with sickle cell disease or trait. And this is the cancer is considered the 7th sickle cell nephropathy. And these are rare but extremely aggressive tumors with poor prognosis. And now we know that there is a specific loss of tumor gene, which are also seen in patients with pediatric rhabdoid tumors and other rare tumors such as the small cell carcinoma of the ovary with that causes hypercalcemia. So these are now are characterized by specific gene disorders, and hence now they're trying to come up with a specific gene targeted drugs in these patients. Again, a very heterogeneously enhancing mass with significant regional lymphadenopathy is what characterizes renal medullary carcinomas. And this was a patient who came for evaluation of hematuria, and not many sonographers can diagnose this small of a kidney mass in a patient who comes for hematuria evaluation. And luckily, this was a somewhat circumscribed mass. So the urologist thought that maybe they can get away with a partial nephrectomy. And when they did the frozen section, it came back as one of these quite aggressive tumors called collecting duct carcinoma. And they had to do a radical nephrectomy because of the histopathology came back as an aggressive tumor. And sure enough, this was a very small tumor, but this patient, despite radical nephrectomy, had already gone to other organs at a microscopic level, and within 3 months of diagnosis had disseminated metastatic disease. Another example of a collecting duct carcinoma, notice that as opposed to exophytic cortical mass, this was the epicenter of the mass is either the deep cortex or the medulla. And notice that it's somewhat hypovascular, And this turned out to be another collecting duct carcinoma. Extremely aggressive tumor because it arises from the renal medulla, which is the hypoxic. And this was the gross pathology and histopathology of that patient with that small tumor, fairly well circumscribed. So looks can be extremely deceptive in some of these tumors, but notice that it's way deep or centrally located or within the medullary epicenter is where the mass is. And that's the reason for the aggressive behavior and histopathology. And most collecting duct carcinomas are not small when they're caught. Most of them are appear as diffusely infiltrative masses that almost replaces the entire kidney with associated metastatic lymphadenopathy. And on the right side, you see a very difficult tumor to see. It's almost imperceptible on corticomedullary phase, but you see this ill-defined hypodensity in the center of the mass, and this turned out to be a collecting duct carcinoma. So some of these tumors may be extremely difficult to diagnose, and misdiagnosis and missed diagnosis are also common, especially when we have diffusely infiltrative mass, and more so with ultrasound. So you clearly need a multiphasic CT or MRI for diagnosis. And here is another somewhat well circumscribed hypoechoic mass. And again, on CT, you see that it's a fairly circumscribed expansile hypovascular mass. And this turned out to be a mucinous tubular spindle cell carcinoma. A long name, but I tend to call this the IPMN of the kidney, or the intraductal papillary mucinous tumor of the kidney. Pardon me. So the Mayo pathologist came up with, excuse me, came up with what they called as the low-grade collecting duct carcinomas. So typically the collecting duct carcinomas are very high-grade tumors, but the Mayo pathologist came up with a specific diagnosis of maybe this is a low-grade or the somewhat indolent type of typically aggressive collecting duct carcinomas. And these tumors had characteristic histopathology. They had mucinous component, they had tubular and spindle cells, and very similar to sometimes it's very difficult to distinguish from the papillary renal cell carcinomas. And these MTSCC, or the IPMNs of the kidneys, are indolent cancers with excellent prognosis. Again, they are typically hyperdense on non-contrast images, and typically hypovascular, very similar to the papillary carcinomas of the kidneys. This is an indolent tumor with excellent prognosis. And I mentioned to you about the Mayo Clinic pathologists coming up with low-grade collecting duct carcinomas. Half of them belong to MTSCC, and half of them were this tumor called the Tubulocystic Carcinomas. These are predominantly complex cystic masses with multiple, this is somewhat very similar to the serous cystadenomas that we see with in the pancreas. So anytime you see a very complex cystic, multiple septations, but not much of a solid mural nodule. So these are predominantly multilocular, multiseptated, complex cystic masses, and extremely very good prognosis, excellent prognosis. Again, this was initially referred to as the low-grade collecting duct carcinomas, but the current nomenclature should be tubulocystic carcinoma, especially because the low-grade CDC doesn't exist. Only the high-grade collecting duct carcinomas exist. And these have a typical bubble wrap consistency. When the pathologists open the specimen, it feels as if they're feeling a bubble wrap. And here is another example of a complex cystic mass within the left kidney with some of them high density, not necessarily enhancing soft tissue component, but this is another example of a complex cystic mass that turned out to be a tubulocystic carcinoma. Now moving on to, so we have discussed some of the cortical tumors, we have discussed something about the medullary tumors, and now we come to the acquired renal cystic associated renal cell carcinomas. So these are the most common subtype that develop in patients with end-stage renal disease. And this is exclusively found, this histopathology, subtype is exclusively found in patients with end-stage renal disease. And here is the pathogenetic mechanism. When the normal parenchyma is destroyed, that leads to hypertrophy and hyperplasia of cells that ultimately leads to cancer. And at histopathology, they have characteristic findings of eosinophilic cells with prominent nucleoli. And the very characteristic is the presence of so-called sieve-like or multiple holes within the tumor specimen. And this is quite characteristic for end-stage renal disease associated carcinoma, as you see here. There's an enhancing mass. And another characteristic is the presence of oxalate crystals at histopathology. So we don't necessarily see the findings, but when they take it out, they have characteristic histopathology. So what we see are, typically these are difficult to diagnose tumors, especially when they're small, but when they're large, they show they may show homogeneous enhancement or heterogeneous enhancement. And clearly, some of these patients can get a contrast administration because they are on hemodialysis. So you can safely give CT contrast on these patients and then they undergo hemodialysis later. Again, there's a wide spectrum of these tumors. And they can be complex cystic masses or masses with significant cystic changes and variable solid components. And sometimes some of these patients who are not on hemodialysis may not get contrast, but then once you see even on non-contrast CT or MRI, tumors that are growing or concerning for these cancers. There is a recently characterized renal cell carcinoma subtype called the SDH deficient, another Krebs cycle enzyme, and that is these patients have dysfunctional or absent SDH in their tissues, and these cancers especially occur in patients with other paragangliomas. So they may have neck or mediastinal paragangliomas or pheochromocytomas, and they may have renal cell carcinomas that are again quite aggressive in some of the cases that I have seen. And some of these patients may, some of the urologists are quite aggressive in that even for small tumors, they may do a radical surgery including radical nephrectomy. So these can be quite aggressive, and if you notice, they're quite nasty looking with heterogeneously enhancing masses with significant necrosis and hemorrhage. Here is an interesting case, somewhat of a hyperdense mass on non-contrast images, and then predominantly hypodense on post-contrast images. On MRI, we see high T1 signal intensity and low T2 signal intensity, and somewhat of a heterogeneous contrast enhancement. And so this turned out to be an interesting tumor called the thyroid follicular carcinoma-like renal cell carcinoma. Extremely rare. It's almost as if somebody transplanted the colloid material from the thyroid and transplanted it into the kidney. And that's how it looks on imaging studies. Just to give a synopsis, we have seen a whole spectrum of common subtypes. The clear cell carcinomas are clearly expansile soft tissue masses that are heterogeneously enhancing, and they show typical hypervascularity. And we see that the papillorenal cell carcinomas, the second most common subtype, showing homogeneous enhancement. At the same time, they are hypovascular. On the other hand, you have somewhere in between are the chromophobrinol cell carcinomas that, despite large size of the mass, shows a relatively homogeneous contrast enhancement and modest degree of contrast enhancement. So somewhere in the between the spectrum of clear cell and papillorenal cell carcinomas. And we have a bunch of so-called rare cancers within the kidney that are less than 1% of all cancers. So whenever we see renal cell carcinomas in pediatric patients, we need to think in terms of translocation carcinomas and renal medullary carcinoma. And if the patient has sickle cell hemoglobinopathy or trait, typically we see them more often in African American patients here, then we should think in terms of renal medullary carcinoma. And anytime we see quite heterogeneously enhancing masses, and especially with a medullary epicenter, then we should think in terms of collecting duct carcinoma or renal medullary carcinoma. And anytime we see extensive lymphadenopathy, we should think in terms of translocation carcinomas, the medullary carcinomas, as alluded to before, and also type 2 papillary renal cell carcinoma, also referred to as the fumarate hydratase deficient carcinomas. And whenever we see complex cystic masses, and they can be clear cell, which is now downgraded to a low malignant potential tumor. And they can be papillary, they can be even clear cell papillary, as we saw in those patients. And tubulocystic renal cell carcinomas can be extremely complex, multiseptated, multilocular renal cells. So you have quite a wide spectrum of tumors that may manifest as complex cystic masses. And anytime we see cancers against background end-stage renal disease, so the most common one is the advanced renal disease associated, acquired renal cystic disease associated renal cell carcinoma, and you can also have other histologic subtypes. In general, renal cell carcinoma is not a single disease. It's quite histologically and biologically quite diverse. Some of them are very aggressive, such as the collecting duct carcinomas and the medullary carcinomas. So some of the other tumors are quite indolent, such as the type 1 papillary renal cell carcinomas. And it is the study of these rare hereditary syndromes that have given us quite useful information about the pathogenesis of even sporadic tumors. And these information have led to important discoveries and inventions in the therapeutic arena, in that we have come up with so many small molecules that are playing a very big role in patients, particularly with metastatic clear cell renal cell carcinomas. Thank you very much for your kind attention, and I hope I didn't go way too much overboard.
Thank you, Dr. Srinivas Prasad.
Yeah, I'm not sure how I can stop sharing. Okay.
Yes, you stop sharing. That was an excellent presentation. I mean, excellent is a very small word to say. I mean, we have never heard anything like this before. That was really great, fantastic. And,
Thank you.
I think Venkat Subbaiah is more excited than anyone else in this crowd now.
Yes, sir. He is amazing guy. He is my guru, my boss. Thank you, Prasad. Excellent presentation. I just want to add